Hello, my name is Jennifer Doyle, and I'm a public health nurse and program manager for maternal and child health. As a public health professional, one of my many roles is to implement programs that address the health of a community, ensuring that there is equitable access to health care and resources for all people. Today I'll be talking about maternal mortality and disparities that occur in this population, particularly non-Hispanic Black women. Additionally, I will highlight the elaborate role systemic racism and racial bias plays in reproductive health and health equity. It is an honor to present to the Bill and Melinda Gates Foundation, and I thank you for having me. So here's the problem. Since the 1990s, maternal mortality has been on the rise for all perinatal women in the United States compared to other affluent countries. Of the maternal deaths and near deaths that occur, over half are preventable. Some research shows as much as 80% are preventable. A disproportionate number of deaths and postpartum complications occur in non-Hispanic Black women. Black women are 2 to 3 times more likely to die in childbirth than white women. While there are driving factors, such as physical, multi-generational, and social factors, recent literature identifies that the broader problem is related to systemic racism that must be addressed to make real change. There's a lot of data available related to maternal mortality, and it can be broken down by age, education level of the mother, race, income level, and other categories. I think these simple but telling numbers do a good job identifying the problem I'm discussing today. The overall maternal mortality rate in the U.S. for 2022 is 22.3 deaths per 100,000 live births. Though this is down from the 2021 numbers, it's still higher than the goal set by Healthy People 2030, which is 15.7 deaths per 100,000 live births. What's even more concerning, though, is the disparity shown between races. As you can see, Black non-Hispanic mothers have 2 to 3 times higher mortality rate compared to other races. This disparity has been consistent over decades. As you can see, some of the major causes of maternal mortality are listed here. For Black mothers, it is a little bit different. The top issues are eclampsia, preeclampsia, and cardiomyopathy, but they can also have any of the above listed as well. Some of the main contributing factors that I've seen in research are underlying health conditions and chronic stress, social determinants of health and how they relate to barriers to care, and structural racism and implicit bias, which leads to discriminatory practices, which also leads to subpar care and lack of trust from the patient. When looking at maternal health from a socio-ecological perspective, we can see some benefits and barriers that contribute to maternal outcomes. When we look at the individual level, one of the benefits could be that most pregnancy-related deaths are preventable, and individuals can help themselves avoid maternal death if they are educated and empowered to receive proper care. One of the barriers is personal factors such as biological and genetic, underlying health conditions, chronic stress, feelings of distrust, and educational status. On the interpersonal level, one of the benefits could be families and supports that can be educated on maternal complication warning signs through campaigns like Hear Her through the CDC. A barrier could be providers need training on implicit bias and racism as it can lead to suboptimal care. On the organizational level, a benefit can be organizations such as the Center for Black Health and Equity, which is an organization that promotes birthing justice and overall Black maternal health. A barrier could be, again, implicit bias and systemic inequalities, creating barriers to access to community resources, lack of culturally competent resources specific to Black women. On the community level, a benefit could be programs like the Public Health Nursing Program that can address Black maternal mortality on a community level, bridging access to healthcare, transportation, and social determinants of health. Barriers can be lack of resources specific to Black women and minimal training for providers and structural racism. And then finally on policy, one of the benefits, policies can be proposed related to equitable care and training and implicit bias. A barrier could be practices within communities that create barriers related to social determinants of health, like redlining, leads to less opportunity for green space, activity, and proximity to health care. I'd like to talk about 3 proposed evidence-based programs to reduce maternal and infant mortality. First one is called Healthy Start. The second one is Healthy Families, Nurse-Family Partnership. And the third one is called Centering Pregnancy. Healthy Start is a program aimed at enhancing maternal health, preventing infant death, and eliminating health disparities. This program provides care coordination for women, children, and partners to address health needs, including social determinants of health. And each Healthy Start program has a community consortium that has a shared goal to support maternal, infant, and family well-being. As a program manager, I would adapt this program to include a community health educator to educate providers and community organizations on cultural competency and implicit bias. The Nurse Family Partnership Healthy Families America program provides home visits that provide coordinated care for perinatal mothers to connect them to resources, relationship building, and family planning. In addition to this program, I would also adapt it to include training from a community health worker into the community to educate on implicit bias and structural racism. Centering Pregnancy group prenatal visits is probably my favorite, and these group prenatal care visits provides 10 prenatal visits, 90 minutes to 2 hours long, and in the group visits they also have one-on-one time with their provider. Group prenatal care incorporates healthcare and patient education, often facilitated by a nurse, and the program delivers a multidisciplinary approach by inviting guest speakers such as providers, social workers, dietitians, dental professionals, and more. The goal is to promote better health outcomes, self-care, self-confidence, more provider time, education, friendships, and support. These group visits would also include training on everybody who presents to the group in implicit bias, structural racism. Some of the partners that would need to be involved in these programs are organizations that address food, housing, and financial assistance, public health professionals, prevention specialists, community health workers and public health directors, public health nurses and OB nurses, medical providers, family and OBGYNs, cultural brokers in the Black community, WIC and SNAP programs, social workers, case management, and any other non-traditional groups that might benefit this population. Some of the barriers and challenges that I probably would encounter with these programs is, number one, reaching the Black maternal population, finding out where they live, where they are, how we can reach them, and this might come in the form of gathering organizations together to educate about our program and educate on how to refer to our programs. Building trust is big. This could be started by training all people involved in the program in structural racism and implicit bias. Transportation and location can be a barrier. I would plan to have the programs located in a place that was convenient to low-income housing or the Black population. And transportation would either be provided on the bus route or within walking distance. Childcare could be provided if necessary, if budgeted and planned for in the program. Staffing is a big barrier because healthcare staffing everywhere is a struggle right now. So we would have to do some heavy recruitment, marketing, and we would get help for that. Obtaining resources for housing is a big one. If we're going to help with social determinants of health, housing is a barrier because there are wait lists and housing that just isn't available in a timely manner. So we would have to get help from community partners with housing. And educating providers in the community about cultural competency, racism, and bias. It wouldn't necessarily be a barrier, but it would be a challenge because this is a structural problem that is really cultural and deep-seated into our culture. For the proposed evaluations for these projects, I would include short-term outcomes, intermediate outcomes, and long-term impacts. And with each section, I would include qualitative and quantitative data. Qualitative in the form of surveys to include providers, community partners, and participants. And quantitative, I would use data to look at how many participants were in the programs, how many prenatal visits did they attend, are they continuing to attend prenatal visits long term, and is the maternal mortality rate being reduced for long-term impact compared to people that did not attend the program. This is my very busy logic model. The inputs include a funding source needed, a place to hold the programs, trainers, people, a training plan, transportation, equipment, materials, and evaluation tools. Activities are what we would deliver in the program. We would develop a work plan, we would hire and train people, we would do outreach with community partners and in the community, and we would provide the deliverables of each program. We would then evaluate the programs ongoing and after. And the outputs, we would look at the outputs being early prenatal care by a medical provider, education from a nurse, connection to needed resources, and provider and partners will have more awareness of racism and bias in the Black population and give more respectful care to perinatal Black mothers. The outcomes and impact, as discussed, we would evaluate with quantitative and qualitative data, with the ultimate impact of reducing maternal mortality. Thank you so much for listening, and thank you for supporting Black mothers and babies. Have a good day.